Welcome, everyone. We'll just wait a moment so that everyone can get in. Okay, well, let's get started. Welcome to the Roundtable series, and this is the 6th and final of the Roundtables, which is really hard to believe, and we are so glad that you're here. My name is Joanne Reif-Snyder. I've had the privilege of facilitating these conversations over the past months since April, when we kicked off this wonderful project that was the brainchild of Erin Vignay. And Erin will close us out today and let you all know what comes next. So for anyone who's joining us for the first time in this 6th of our 6 roundtable discussions, these conversations have been modeled after the age-friendly health systems for EMS, which, as you know, are what matters: medication, mentation, and mobility. And they were adapted to be specifically considering the needs of our Careforce. Lori Porter is the one who prompted us to think about our workforce as a Careforce, and many, many people have taken up that term now. So in terms of the Careforce, what matters, we've talked about facility culture, respecting individuals, especially those who are on the front lines, closest to the residents, CNAs, and others, and giving people a voice. Medication, we focus really on health promotion and workplace safety. Mentation was focused on well-being of staff with a focus on stress management, compassionate self-care. And then finally, mobility, we really looked at career mobility, so opportunities for personal growth and advancement. We have been a community focused on co-design. How can we come together and put our best ideas out there on the table, and through small tests of change, teach each other and all learn from each other. And then Erin will talk at the end, as I said, about collation and dissemination of the insights. She's been posting those after each one of these meetings, and then many of you have participated in an online community talking about the work as well. So here are the topics for those who maybe hadn't had a chance to attend them all. We are here on September 22nd, talking about the role of leadership in staff growth and retention. So really caring for the Careforce. What is the leader's role? What kinds of actions should we be taking? I am delighted to have 2 guests. We are delighted to have 2 guests with us today. And some of you surely know Dr. Asad Zandi. She is a graduate of Mercyhurst University and WVU School of Medicine, where she also completed her family medicine residency. She then pursued a geriatric medicine fellowship at UPMC Presbyterian in Shadyside, and is now a clinical assistant professor of medicine for UPMC's Division of Geriatric Medicine. And she also provides care at Asbury Heights, which is a CCRC. Her research focuses on frailty evaluation and treatment in post-acute and long-term care, and educational pursuits are focused on increasing resident and medical student presence in post-acute and long-term care settings. We also have Dr. Nancy Istanis, who is the Chief Medical Officer for Saber Healthcare Group. She is a graduate of the Philadelphia College of Osteopathic Medicine and completed her residency training in internal medicine in Pittsburgh, and a geriatric medicine fellowship at the Cleveland Clinic. She's board certified in internal medicine and geriatric medicine. She practiced at SUMA, or SUMA, I'm not sure, Nancy, you have to tell us what that is, health system in Akron, Ohio for 15 years, and specialized in developing innovative models of care delivery for complex medical patients. She has always had a passion for nursing home residents and has spent a large part of her career working in a skilled nursing facility and a long-term care setting. She's a certified medical director, and chairs the Workforce Development Committee for AMDA and is on the board of directors for the Ohio Medical Directors Association. And I love when she's not working, you'll find her relaxing with her husband at their home in Hudson, Ohio, or traveling, and she's almost always knitting, which I particularly love. So I teed up some questions for today's discussion, and I'd like to hear from Shauna and Nancy first. We'll have a conversation. I'd like others who are joining us today to enter into the conversation at any time. Chat in a question, raise your hand. We want to get you involved in the conversation as well. And I'm going to go in the order that I see you on my screen. So Shauna, you happen to be up first. Could you tell us a little more about yourself and your perspective, and maybe talk a bit then about the first question? What can medical leaders do with respect to the Careforce?
Yeah, so I have had a very long sort of path in long-term care, despite the fact that I haven't been in medicine for all that long. But my mom was actually a CNA in a facility when I was a child. And so I spent a lot of time in that facility because of that. And I spent a lot of time with her and sort of seeing the struggles from a standpoint of being a certified nursing assistant. And then, kind of full circle now, I get to see it from the perspective of being a physician in a facility. And I feel like my biggest sort of takeaway, and I'm still learning this, but my biggest takeaway is just that, the nursing home is nursing run and it's a team-based thing. And I think it's been top down for so long. And I really would love to just flip that over, because I really feel like our nurses and our CNAs are like what we should be propping up and listening to and really giving a voice to, trying to keep them in this, it's like wanting to do this job. And I have, a few things, in my opinion. I feel like if we invested in our nursing assistants a little bit more, and it wasn't considered this, dead end job, in the sense that you get to a certain point and there's nowhere else to go. Like, we invest and we help them get whatever their next goals are. And if they want to go to nursing school, that's great, because then you've built your nursing force. And I don't know exactly the best way to go about doing this, but I have years to figure it out, I guess. So that's the good part.
Great, thank you. Well, we're going to delve into that a little bit more. What sort of specific things do you do when you're rounding or when you're out there, in the setting where you're encountering staff? But Nancy, let me invite you, if you would, to tell us a little bit more about yourself, your passion, and what your thoughts are about specific actions that medical leaders in particular can take to strengthen the Careforce.
Right. I think it's overwhelming at times, right? Because we look at how many people we need as a Careforce kind of in our facilities, and what we need immediately. So there's this piece of how do we pull people out of the community to kind of take jobs in our facilities currently, or take nurses that are maybe employed in other sectors of healthcare and bring them into the nursing home. And that's one hurdle that we have to take. And I think there's a lot of things of, building those care ladders, really promoting that, working in our environment for a physician, there's great work-life balance. There's a lot of flexibility that an office might not have. So I think that if we want to take the current level of providers that exist in the medical systems and kind of introduce them to long-term care, I think there's a lot that we can do to kind of promote our industry, can help to offer training. I always say, though, it is the kind of the world of MacGyver. You don't have a CT scan down the hall. So we also have to offer some kind of training for that medical professional, whether they be a nurse or whatever, or a physician coming in. But then I think we have to look beyond that. And we have to look of who's going to be the Careforce for our buildings in 10 years. Mm-hmm. Who's going to be the Careforce for our buildings in 5 years or in 15 or whatever that piece was. And I think that's where it starts to get back to, us each asking ourselves, why did we go into long-term care? And when did we first have our exposure to long-term care? Shauna mentions that her mom was a CNA. I'm going to bet that her mom took her to work with her. And Shauna probably helped with activities and passed out popcorn and just did things in buildings. I look back, and the minister at our church, his wife her mother was in a nursing home, and she, about one Sunday a month, would ask my parents if I could go with them, because I would both visit her mother, and then I would play with her kids and be a little bit of like supervision. But as a young child, I was excited to go on this adventure to the nursing home. And so the nursing home then has never been a scary place for me. When I graduated high school, and a friend of mine who was in nursing school, and I was looking to go pre-med, but she told me that she got a summer job at the local nursing home and they trained her to be a CNA. I was so excited because I got to touch patients. And so I became a CNA, worked through college and a little bit of medical school, doing some shifts and things and summer stuff with that. But that really cemented that this was a good place to work, and it was a good place to care, and it was a good place to deliver care. And I wanted to be part of that. There was an educational program when I was in high school. It was affiliated with a Boy Scouts called the Explorers, but we went to a VA hospital, which was really a nursing home. I mean, that's how it was structured, more like a nursing home. But we spent time with therapists and activities directors and doctors and nurses and, therapists, everyone, and really saw that the goal was to explore healthcare careers. And we did that. And then we spent some time as part of that volunteering at this basically VA nursing home. But again, I think it demystified things. So I really am a big proponent that I think we need to move this back. And as medical leaders, can we reach out to the volunteers at our hospital and have them come and shadow us and bring them, come shadow a doctor, bring them into the nursing home, but then show them the opportunities to volunteer there or become a CNA, and that this is a valuable job. And maybe they will stay in this career. Maybe they'll move to other healthcare careers. Maybe they won't be in healthcare long-term. But we have to get people stepping into the nursing home and realizing that it's a good place and it's not scary. And for the last 3 years, it's been a black hole through COVID. Most of us maybe even, walked into a nursing home to visit grandma when we were young. And that there was something about it that sparked us. Kids haven't been doing that. People leave their kids at home now. So I think that we have to figure out how to open the doors. And I think a lot of times as leaders, we can really help to do that. So, high school students will want to come and shadow a doctor or have that kind of day, or shadow a nurse, but then they can look and see what are some of those other, opportunities that exist in this. So I think I always look at it as we have sort of two issues. We need to pull people out of the current healthcare arena into our arena, and we need to show them that this is a really great place with great work-life balance, and you feel like you're giving care and great rewards, and train them how to do that. But we've got to get people really interested in caring for the elderly and in nursing homes. And we need to start with kids to get that, to build.
Thanks. That's what a great point. And we talked, Shauna, when we were doing our prep call, we talked about this a little bit as well. My mother was a director of nursing, and I was asked when I was 16 years old to please put on one of her uniforms and come down there because she needed me. She was the director of nursing in a small nursing home. There was no certification for nursing assistants back then, but I became one and fell in love with the people who lived there and got to see what it really meant to care for people in a setting like that. And while you're not suggesting it for this reason, and we know we won't solve our immediate staffing issues, but we need to think long-term too, and sensitizing young people to the environment so that it's not a big, scary, really, I think is a wonderful step. And I do wonder if others are doing that. If you have any opportunities, maybe you haven't been able to restart them since COVID, but we'd love to see that in the chat. If anybody who's working on those kinds of initiatives.
Right. And I will say, like, we are, so our company, I mean, we're trying to offer scholarship, like, we've developed some scholarships and we call it our student success program. And we're starting to partner with schools, and that's kind of the immediate workforce. Now we're starting to partner with high schools. So, they need volunteer hours. Can we bring them in? How can we kind of build this? But I think really helping people see that there's, my other example is I have a really good, my best friend's son kind of stepped his foot in college and said, like, this right now ain't for me, at this point in his life. And he had been kind of working in some food service, but a lower end of food service. And we're talking, I'm talking to him about opportunities. And I said, why don't you think about going to work at like a nursing home? There's food service, there's food delivery. You can see all of these other career options, and it's a great way to kind of like explore. So I think building, how do we get these people that, even we need a Careforce is, our food service in the nursing home. I mean, that's part of delivering care. And I think a lot of people that are in the food service industry never think that, boy, I could do my job in a nursing home and really feel like I'm benefiting somebody.
Mm-hmm.
So I had like one of the University of Pitt students just reached out to me this past week and said, hey, I've been a CNA the last few summers. I'm applying to medical school, but I really would like to shadow a physician. And I'm really interested in the nursing home. And I was like, oh my goodness, where do we find 10 more of you? And like immediately it was like, yes, we could get you to the nursing home. But I think it is that is completely it, is like, there's so much, I think, I don't know if I want to say fear, but just like I will talk to a lot of residents and they'll just be like, yeah, it's just really like the nursing home seems really sad. And I'm like, it's not though, but that they're not exposed to it enough to understand that it's not. To them, it's this like area where we send people who are very, very sick, or this area where people who are very, very sick have to go live. And I think it's just exposing them to like actually getting them back in. And so we're trying so hard to get the residents and the medical students back in to the facilities and rotating back in, because I think if they see it, first of all, they understand where they're discharging these patients to, but also just getting over that fear that it's not a scary place to be.
Yeah, that's a great point. I think that much of the way that the nursing home is portrayed in the media, and particularly through COVID, where a lot of scary stories were coming out, that forms people's impressions about what the environment is like, for sure. What kinds of things are each of you doing to really engage with the other staff across disciplines in the facility? We know in particular, nursing assistants often feel that they're not really very integrated into the team. They're not respected. They're not even visible. Sometimes they feel. How does your role intersect with what they do? Does it at all? And what does that look like?
I sort of almost not really force it, but if I'm going to go see a patient and there's something wrong, that's like the first person I'm going to go find. And I feel like there's this like, oh, well, like there's not enough training there for them to make. And I'm like, I'm not asking for a medical judgment. I'm asking for an observation. And they spend the most time with those residents. So if I'm being told that a resident is, acting up and misbehaving, but they do this every day at 3 p.m., the CNAs are going to know better than anybody. So that's the first person I look for when I'm running around, is who's the CNA that has this person most often.
That's great. What kind of response do you get from them, Shauna, when you do that?
Sometimes it's surprise. I think they're like a little shocked that I'm asking, or like a little like, well, I don't know what to, like, I don't know medically what's wrong. And I think it's just that's when I usually tell them, like, I just want to know what you're seeing, because you're seeing things that a lot of us are not seeing. You're seeing it from a perspective that a lot of us are not seeing it. So I love finding them. And I think for me at least, it's given me a lot more, I like going into the nursing home and like knowing everybody's names and being able to like talk to them, and then they feel more comfortable coming up to me when they see something that's not right.
Well, that was sort of my follow-on question then is, do they seek you out? You seek them out and then they seek you out also. You've sort of normalized that, made that possible for them to do that.
Yeah, and when previously I was in a very small nursing home in West Virginia, and I had been there for 3 years, and I had a great relationship with all of those CNAs, and they would come find me. They would just be like, "Hey, this is not right. We need you to look at this." And then now I'm sort of in a bigger facility in a CCRC, so I'm learning all over again. I got to learn everybody's names now.
Great. And Nancy, how about you? What's your engagement and interaction like with staff across disciplines, with nursing, all members of the nursing team? What does that look like?
Right. So, I mean, I can speak a little bit, when I was in practice versus now I have kind of a corporate role. And I think that, in practice, I very much, and even today, I'm very cognizant of kind of this really rigid hierarchy in healthcare and how sort of the fear that exists. I mean, there are, I spend a lot of time in my corporate role now working with administrators and directors of nursing who maybe are having a problem or a challenge with their physicians or their medical directors, and just coaching them how to talk. My first question is, have you talked to them? No, okay, well, let's talk about how we're going to have that conversation. And I mean, these are professionals, but they struggle. And so I really realized that, the STNAs, sometimes it depends on where they come from and the culture of prior nursing homes before they came into the nursing home we were in, that they often didn't feel like they could reach out or even tap me on the shoulder, or call my name down the hall and talk to me and say, I don't like the looks of so-and-so, or I'm concerned about this, or what do you think? So I've really learned that you have to kind of go to them and show them that you're approachable. I would pack my lunch every day because I, work through lunch. But going into the employee break room and sitting down and eating my lunch there and just saying, or heating it up and what are you having and tell me about your kids, or having those just personal conversations instead of getting those blinders on where we just are there to do a task and then leave and get in our car, sitting at the building and encouraging providers to do their documentation in the building. Keep your laptop, do it in the building. You're there for a couple of more hours, but you're going to do that time back at your office or wherever, do it in the building, and then you're approachable. And people will start to see that. So the more that you're approachable, you show them that you have bad days too, or you're concerned, the more you ask them questions, the more they're going to then ask you questions. I think from a corporate level is really starting to break down. I mean, I just start with our DONs and administrators, and I talk to every one of them through orientation, and just even letting them know that they can reach out to me. They're like aghast. They couldn't imagine. And I'm like, no, like you should have me on speed dial. I want to get a call from the building. And so you realize that there's just that hierarchy, in our organization, our CNAs don't have emails. They don't have email addresses from us. So it's hard to even send out a message to all of them. So we've really, trying to look at what are those barriers. We're trying to figure out how do we address some of that, and then how do we add supports in, so where we can, educate, train, provide kind of work-life pieces to make them realize that, all chains are really connected to them.
Mm-hmm. That's great. So I'm hearing lots of good suggestions here, from engaging with CNAs, and Shauna, I'm sure you would say with any member of the nursing team, when you're out there and have a question about a resident, really creating that interprofessional intersection there. And Nancy, as you're saying, really being visible throughout the facility, and not just sort of coming in. Everybody's busy, and certainly our medical, our physicians and others are as well, but really being present And then in your role now, sort of identifying what are some of the hierarchical barriers to really greater interprofessional collaboration and attacking some of those. These are all great ideas. And Erin just put in the chat, and I agree, emails for CNAs. I hear that a lot. That's actually fairly common. So if we don't have a communication platform that reaches everybody, then right out of the gate, we have a barrier to integration and engagement. So these are great ideas. I want to invite others to join the conversation too. We do have a comment from Victoria today. Victoria, I'm glad you could join. Really talking about service learning volunteer programs, and as you were referencing earlier on, like the STEM momentum years ago, a national initiative on healthcare is absolutely needed that would get kids, young people out into our care centers. I love that. And Nancy Zients, who's joined us today, early sensitizing to elders is important, destigmatizing. Hebrew Senior Life in Boston does have a wonderful intergenerational program with schools. So there are lots of opportunities for that kind of integration. Thanks for all those ideas. And Nancy, yes, engage with all three shifts. The night people, there's a reason it's called the graveyard shift, right? Nobody's around. It's really kind of empty out there. So greater engagement there. Amy Berman, hi, I see you have your hand up.
Hi, Joanne, thanks. This is such a great dialogue. And I'm keenly appreciative for all 6 of these gatherings, and I look forward to hearing the next steps. One thing that, I also come from long-term care as a background, and one thing that we found is when people are being engaged to speak up and offer observations, while a paraprofessional may not assess, they observe, and those observations are really critical, but they oftentimes then don't get the feedback how important their observation was. Mm-hmm. So I would just add that to the, all the other great ideas, that feeding back to somebody the really positive feedback about what they did for that resident is a component to consider.
Great point, Amy. Thank you. Let's see.
Yeah. That was awesome. And on it, like, I will often just take, if they're telling me something, I'll just keep the CNAs at bedside, and I'll just be like, yeah, this is why this is happening. And it's a little bit of education, even in a sense, but it's then they make that connection next time. They're like, oh, they're coughing because they were not sitting upright. We need to do a better job with sitting them up when they're eating and drinking. It's going to have downstream effects if we continue to do that.
Yeah, it's such a great point that really positive feedback is not something we should be saving for performance evaluations, which don't even happen very often anyway. It should be timely, specific, and public. When we see people doing something that's really contributing to the quality of care, or the quality of the Careforce, we should be calling those things out and reinforcing them. Lots of great things coming into the chat here as well. And let me just see if there are any other hands up. Sorry, I'm trying to look in a lot of places. If anybody has a question or a comment, please feel free to raise your hand or chat them in. Gina says that she was involved in an adopt a grandparent program as a child, and I visited my grandparent at the nursing home at least weekly for about 2 years. That's awesome. When I was, I ran a health office at the Philadelphia Senior Center for a few years with students, and we did ballroom dancing with these tiny little kids who came in, and they found their grandparent, whoever was assigned to them. I was in my 30s, I think, but I was a grandparent too, because we all look the same when you're 5, and what a wonderful experience of normalizing aging and being with older people. Cheryl says, I learned at the annual AMDA meeting about having medical director hours for staff to be able to stop by. Oh yeah. Initially, the administrator was supportive, but then shut it down before it started, saying that was HR's role. love to hear some other comments about that. When I was at Genesis, I think one of the most impactful people in the entire center was the medical director, and their willingness to be accessible and talk with staff was just a driver of Careforce Health and many other things. Andrea says, when I worked on the behavioral support unit during team rounds, we'd have a CNA be the first to speak when discussing the residents' behaviors. How about that? There's a small change we could all make by next Tuesday, a la IHI. They felt valued and were more willing to make comments and suggestions on behavioral strategies. I just love that. And then Gina, it does help support the love for the nursing home world at a young age, but couldn't agree with everyone more. Leadership, building relationships, and understanding and sharing our whys as to why we're doing this. Awesome. Are there other actions that folks are taking, people who've joined us today? Anything that you've tried from any of the sessions, the conversations, well, this is the sixth, the other conversations that we've had? What's worked? What are you thinking about trying? What matters most to your Careforce? How do you know? And what are you working on there? We'd love to hear from you about that. And while you're thinking about that, I want to ask Shauna and Nancy to comment on Aaron's question here, which is, what could AMDA do? How could AMDA be a better support, stronger support, or accelerator for post-acute long-term care leaders' actions to grow and strengthen the Careforce?
I'll echo, so one of the comments in the chat, was talking about kind of my thought process of getting people into the nursing homes and getting them this experience of being service learning. And they said kind of like the STEM momentum. I was also referencing back, years ago, there was a shortage of teachers. There is again now. And so there was, federal funding aimed at, people going into teacher training, loan forgiveness focused that way. I think there's a lot of political advocacy that we can do to try to raise an awareness that, healthcare in general needs an influx, and then long-term care also needs, a good focus in that influx. But we need to really start putting kind of national workforce development and making sure that we have a foot in the game, like that we are part of one of those alleys that we're going to start focusing, younger individuals into thinking about healthcare and healthcare careers. So I think there's a lot of political advocacy that we can do there. I think there's a lot that we can do in just education about working in our space for current providers. There's a lot of burnout in healthcare. And I think people have seen kind of the trauma of COVID, and they don't see that our sector in the nursing home is a good place to work. But there is some flexibility, right, in your work hours. And if your kids call and you have to leave at 4 but come back later or come another day, you can kind of do that. So I think that we need to promote that, are you tired of your 12-hour shifts as a hospitalist? Are you tired of running that same rat race? Here's a way with no overhead like an office that you can work and make a huge impact. So I think we can do a lot to advocate for resources and to really promote. And then, I think we do a lot to focus on training medical directors or training in the future, maybe people who are just coming into long-term care. We need to get, what about how do we train the people that long-term care is their second phase of their healthcare career?
Great.
Yeah, I do. I want to echo the fact that I think like there needs to be a way for us to change how we look at long-term care, and also to incentivize wanting to work there. And so I can't say enough about that. I also feel like from my perspective, it's really been me focusing on like helping, and like my goal is to help with bringing the interdisciplinary team into AMDA. And so, Tess and I have talked a lot about making Caring Through the Ages actually like have sections for CNAs, sections for rehab services. So it's not just aimed at the physician, and bringing the voices of all of those levels of leadership into the organization. And so I think that's like more of a long-term thing, but I think that would be fantastic. And I agree, in the short term, we have to find a way to incentivize bringing people into this Careforce. And I know we've all already seen the studies that we know that like more money isn't necessarily the way to do it. So we have to create a system that people actually want to be a part of.
Yeah, no, absolutely. One of the things I was reminded of some focus groups we had done with employees when I was working with Genesis, looking at, we did exit interviews like many folks did to try to understand why people left. But one of the most important things we did was sit with people who had been with us for many years, decades, some, and ask, what retains you? Why are you here? Like what keeps you coming back every day? And generated stories of compassion that were truer than anything that I could have said, because they were there doing that important work on the front lines. Let's see, Jeffrey says, program for high school students. Sounds great. How it says, since COVID-19 and HIPAA issues, as well as recent cases of young people being abused, how are you handling this? I don't know if anybody has any thoughts on that you want to speak to or could chat in. Any ideas to reduce care burden on staff via certain types of tools like electric pill crushers, bladder scanners, other types of things like that? Great ideas, great questions here. And then Cheryl says, I think partnering with other organizations that represent other parts of the ECF world, such as Leading Age, HCAM, that represent the facility is something that AMDA could do. So maybe a broader set of relationships. And I think that's, Nancy, what you were saying too early on in your remarks, sort of joining with other organizations that are looking at sort of a national workforce strategy. Am I saying that right? I don't want to put words in your mouth, but you were talking about that as well?
Yeah, I mean, I do think we all have to kind of work together, but there needs to be a unified message. Like, and I think the STEM example is a really good one. There's been a lot of campaigns about, introducing like STEM in childhood, but especially STEM to women. We could be talking about, long-term care, but to all areas of healthcare, diversity, but making sure that the message sounds pretty similar no matter which organization is delivering it.
Great, thank you. Well, this 45 minutes has flown by like it usually does. We could have talked on and on. I do want to bring Erin into the conversation. I want to thank you for this incredible work, Erin, that you've put into this. This was your project, and you've really generated a lot. And so now I want you to take a few minutes, if you would, and talk about what your plans are for next steps.
Thank you, Joanne. And first and foremost, I just want to thank you for all of your help. Joanne has been my fellowship mentor. It's been a pleasure. And I feel like I've gained not only a new mentor and friend, but really a partner in this, because I think she's as passionate about this as I am. But I really do appreciate all your help with this. She's helped me find speakers and kind of tailor what we're going to be talking about. So it's been a huge help. So thank you so much. And I think it's just the beginning, I hope. Also, I want to thank our speakers from today, Nancy and Shauna. This was a really great discussion, and what a wonderful way to tie things up for now of this program. I really appreciate it. And I think we even have a few past speakers on the call today. So it really was some rich discussions. And so finally, I want to thank all of you, our participants who've come. Some are newer to this, some have been here with us since April, since we kicked it off. Your comments, your suggestions, your feedback have been really helpful. And again, these are roundtable discussions and it's crowdsourcing. And so your input is what's shaping the strategies and helping us to disseminate your ideas and what you're doing. So I know I've been asked a few times, what's next? So basically what we're looking to do is partner with which some of you have mentioned with partner organizations. So if you're with an organization who's been attending these and wants to help us continue, we're looking for partners. Also some additional funding, perhaps from the AMDA Foundation. We're going to look to partner with them, but other groups as well who might be interested, nursing organizations and so forth. Because what my goal really is one, we can find a way to continue these roundtable discussions, which I think would be terrific, but also to take the strategies, the so many strategies, as Margot said in your post, that we've talked about over these last 6 months, and to find a way to compile them in a way that's usable and that we can disseminate to other audiences across the nation. There's so much that was talked about that I don't want to just end it and have it kind of be in the recordings on our website. So we're looking at some ways to do that. And I'll ask really want to do some focus groups as well. So you may be hearing from me. I'd like to do some focus groups to get your input on what resonated most with you during these discussions, some strategies you may have tried, or that you didn't, and why not, some barriers you faced, as was discussed a little bit today in the chat too, and that will really help us as we kind of build this product of strategies to help disseminate what we've talked about. So you'll probably be hearing from me soon. And again, I really appreciate all of your support through this. It's been just terrific, and I have learned so much. So thank you.
Well, thanks, everybody. I think we do have to close now, and keeping on time. As Erin said, look for more. This is not over. Thanks to everyone who's participated. I see so many names that I recognize now because you've been here at each session. And many thanks to Nancy and Shauna today for joining us and sparking a really great conversation, and for your leadership in this post-acute long-term care world. Thanks, everybody. Bye-bye.
Thank you.
Thank you.
Bye-bye.